We will be recording this session. It will be uploaded on YouTube. So we usually have a little bit of a question and answer session at the end. So any questions that you might ask will be public. But without further ado, I'm going to go ahead and get started with our Building Strong Brains Learning Collaborative webinar. We are so excited to have Dr. Andi Clements and also Becky Haas here with us today to talk about the toolkit that they developed to support trauma-informed communities and organizations. They have done so much work in the Northeast Tennessee region and have really been not only local innovators but national innovators in the work that they do. So I'm going to read each of their bios really quickly, and then I'm going to pull up their presentation and let them get started. So or Andi Clements is a professor and assistant chair in the Department of Psychology at East Tennessee State University. Her main areas of research are religiosity, health, and trauma-informed care, particularly with regard to addressing addiction. She is leading two funded projects. The first project, funded in large part by a HRSA grant, is being done in collaboration with multiple community partners and Duke University's Theology, Medicine, and Culture Initiative. It seeks to mobilize churches in a 22-county area of Northeast Tennessee and Southwest Virginia to address addiction. The second project is in collaboration with Becky Haas here today, who is the trauma-informed administrator with Ballad Health, with whom she has worked for almost 4 years training thousands of individuals in trauma-informed care and ACEs. They are now creating a toolkit, which they're presenting on today, to guide communities to build community-wide systems of trauma-informed care. So Becky Haas is a trauma-informed administrator with Ballad Health, and she is, in her role, she is developing and implementing trauma-informed care programming throughout the 21 counties of Northeast Tennessee and Southwest Virginia served by Ballad Health. This programming is aimed at reducing the effects of adverse childhood experiences, which can be a significant risk factor for drug addiction and other life and health disparities. Prior to working at Ballad Health, Becky was employed by the Johnson City Police Department, first as the director of an $800,000 grant funded by Targeted Community Crime Prevention Program, which later expanded to overseeing crime prevention programs in 2016. These efforts included the creation of the Day Reporting Center, which was the first probation program of its kind in the state of Tennessee. In 2014, the TCCRP won national recognition by receiving the Outstanding Criminal Justice Program of the Year award for the Southern region from the National Crime Justice Association. At the end of the successful TCCRP grant, the Tennessee Department of Corrections acquired the Day Reporting Center and have replicated the model throughout communities in Tennessee. During her tenure at the police department, Becky first heard about trauma-informed care and ACEs science, and living amidst rural Appalachia, which has seen devastating effects of the opioid epidemic, Becky felt that this was a message that urgently needed to be shared within her community. Partnering with the faculty from East Tennessee State University Psychology Department in 2015 and receiving technical assistance from the SAMHSA-funded National Center for Trauma-Informed Care, they trained over 4,000 professionals in less than 3 years and created a growing trauma-informed system of care, which has over 40 affiliated organizations. In September of 2018, SAMHSA officials recognized their work as a community model for other cities to follow. So Becky is a seasoned public speaker. She does a lot of work for the Commission on Children and Youth. And her first book, Your City is Waiting on You, based on her experiences working at the police department and how she invited the local faith community to hear the conversation of citywide needs and how they responded to become a greater resource in meeting these needs. This book was published in August of 2017. Most importantly, Becky has been married to Jonathan for 34 years, and the greatest joys in their life are their two sons, David and Christopher, along with their wives, Katie and Stacy, and their two grandchildren, Paisley and Caden. Love it when people add that kind of context. So without further ado, I'm going to pull up their presentation and also unmute them so you can hear them. I hope I'm going to unmute them. Bear with me. see here. Of course, there's always an issue with technology. You wouldn't believe it, but we literally just tested this not even 10 minutes ago. There we go. Becky, can you hear me now?
You can.
Perfect. Good deal. Okay. So I am going to share the presentation. And I am going to assign control.
I believe her.
All right, Andi. Andy and Becky, take it away.
Taking control. All right. We have the technology, I think. Okay, so.
Okay, so good afternoon, everybody. We're really excited and honored to be kind of sharing our story. So what we're going to share today is sort of a summary of the toolkit that we submitted. We had a Building Strong Brain grant last year to write a toolkit on how to trauma-inform your city or community based on lessons learned in Johnson City. So that's really what we're going to be sharing today. Hang on.
Well.
Okay. So in 2014, when I first heard about trauma-informed care, simultaneously SAMHSA released a concept paper entitled SAMHSA's Concept of Trauma-Informed or of Trauma and Guidance for a Trauma-Informed Approach, and you see there a cover of it on the slide. And in that concept paper, they made this recommendation that communities should address trauma through a multi-agency public health approach inclusive of public education, awareness, prevention, and early identification, and effective trauma-specific assessment and treatment. So my role then at the police department was to reduce drug-related and violent crime. And when I heard that the ACEs study showed the significant risk factor of addiction related to childhood adversity, I really felt like it had to be added to our toolkit. So in reaching out to SAMHSA, found this concept paper with this recommendation. And one thing at the police department, I was already working with 35 organizations to do 19 programs. So we were already had a collaborative. So that really provided a springboard to our community to begin this effort. So then in 2017, we wrote back to Joan Galeese at the SAMHSA-funded National Center of Trauma-Informed Care, and we asked to host a webinar in 2018 because we wanted to talk to the other cities that had followed this concept paper guidance. And at the same time, the Center for Disease Controls had some similar recommendations to train a cross-sector approach, law enforcement, healthcare, so that your whole community had the trauma lens. So it wasn't really till we reached out about doing a webinar that we really learned that something out of the ordinary maybe happened in Johnson City. And so this slide here was the response that came from Dr. Galeese. She wrote back and added this statement that though many communities across the nation are beginning to implement some of these SAMHSA recommendations, Johnson City clearly stands out as a leader in embracing this model. So in 2018, she came to Johnson City, and we hosted a forum, and we had two governors' wives come. Miss Haslam was still our first lady, and Tracy Carney. Miss Carney heard about it through the Annie Casey Foundation. They had been working with her and Governor Carney in Delaware to do some initial work to help them see the role of the trauma-informed, the importance of trauma-informing a community. So the Casey Foundation is how I connected with Miss Carney. So she came to our forum. And then after Ms. Carney visited, Governor Carney signed Executive Order 24 in October of 2018, stating that if you do business with the state of Delaware, that you have to understand trauma-informed concept. So I've had 2 trips to Delaware at the invitation of the First Lady and helping to launch that initiative. Also at the forum, we had people from 20 states that came, as far as from Utah, Vermont, to learn about what had happened in Johnson City. So this was in writing our toolkit. I reached out to Ms. Carney, who's now become a friend, and I didn't know if it was appropriate to ask First Lady to say a few words, but she was very, very, very excited to be included in our toolkit and as far as writing an endorsement. So this screen is her endorsement. The Johnson City model, trauma-informed care, has been a tremendous inspiration for First Chance Delaware and many of our partners. Understanding trauma is a prerequisite to any strengths-based work with children, families, and communities, and a multi-agency public health approach is the only way to get there. The Johnson City system of care is a great example of how to integrate the development of formal support with a promotion of public awareness in a science-based, goal-oriented, and sustainable shift in culture. This is what our cities really need. So we certainly appreciate her kind words about our efforts.
And so one of the things that that from looking at the concept paper that was written, one of the things that we realized, and only recently have numbers started to come out about the number of ACEs experienced by Tennesseans and so forth. We've been addressing this through the Building Strong Brains efforts over the last several years, but we know now how prevalent it is, and we're preaching to the choir to try to tell you that this is that adverse childhood experiences are an issue here. So we just popped a couple of numbers up there. But one of the things that we see is that if the community, if every community is so impacted by this, the community's got to be involved in those solutions. And so, and just at the risk of making Becky's head swell, when she first drew me into this work, she had already seen down the road that this is going to have to be a system of care. In fact, we talk about the notebook, which I think we'll talk about a little bit, that she went out and started looking at all the sectors that had trauma-informed just development happening in every sphere that you can imagine, and made a notebook of some of these back before anybody was really doing that much of this, it seems. Early childhood folks were, but not so much in the general helping community. And so she saw this as a kind of a goal down the road, and now here we are sitting talking to you about it. So we do want to say that we have involved a lot of our community, but any community can involve their community. And so that's one of the reasons the toolkit seemed like such a good idea. And so knowing how prevalent trauma is, and I love this slide, she made it so I can say that, is that if you knew on any given day that 70% of the clients who walked into your agency spoke French, you might do something about communicating with people in French. If you knew that they were going to need a wheelchair, you might have structural differences. If you knew that they were hearing impaired, you would have accommodations for that. Well, we know that particularly in social service agencies, that a large majority of our clients have experienced some sort of trauma or have family members or children or whatever. And so that's a thing that we very logically should be prepared for as we consider our services and so forth. And so that's why it's, and also people that we refer to. And so that's why it's so important to have this to be a systemic effort.
So I was presenting back in the spring for TBI at their Senator Tommy Burke's Victims Academy in Chattanooga, University of Chattanooga, to 70 advocates from across the state. And I was training about why trauma-informed multidisciplinary teams should be best practice. And so I gave the group that day 3 case studies, and I asked a group to come and address each one. And the first study was a married victim with children who's subject of ongoing domestic violence. The second case study was a 21-year-old college student who was a rape victim. And then the third, an 8-year-old victim sexually abused by those that frequent the home around the child's addicted parents' activities. And what I asked them to do is on each of these scenarios to list the number of organizations that could be a touch point for for navigating these difficult situations. And in every situation, they easily name 6, 8, 10 organizations. And so my point there was that what if only 2 of the organizations have trauma-informed or trauma understanding? So you have 2 organizations that understand the role trauma plays, and they want to not re-traumatize someone in offering services, but yet 6 of the others know nothing about trauma. And so maybe they're faulting them when they miss appointments, or maybe there's language that's more shaming or things your own fault. And so why that we really needed to have all of our system partners on the same page when it comes to understanding trauma. And so kind of some of the thought process for a system of care is that most systems engage with victims of trauma. Like Andi said, about 70%, according to the national numbers, there's a high rates that our services, we engage trauma survivors. So kind of my thought process as we were developing this system of care was that if a child is experiencing domestic violence at home or ACEs, it's unlikely the child will be brought by the parent to see a mental health professional right away, if ever. Maybe that's something that's going to come out in a group therapy when they're a young adult in their 20s and they're now struggling with addictions. And in a group, they talk about witnessing violence in their home. And so I thought, you know, by law, the child does have to go to school, might play sports or attend an after-school program like Boys and Girls Club. So why not train each one of these to be trauma responsive? And so that your trauma awareness can be included in all your frontline services in order to reduce the effects of ACEs. And if you think about it, that children living in a home with ongoing toxic stress, together as a community, we can reduce the effects of ACEs by having a trauma-responsive community. Together, we can train people from all disciplines that you don't have to be a therapist to be therapeutic. I don't think it's in this slide deck, but I get some of the most wonderful slides and photos sent to me now from around the nation. And one was sent to me of a fireman, a first responder that was at a traffic crash. And while he's laying on the street in the midst of glass and blood, it's a bad scene. There's a child on a board waiting for the Wings chopper to pick up the child and transport the child with injuries to a hospital. But this wonderful first responder is laying there amidst the glass on his phone watching Happy Feet with this little child. And I can promise you that when that child gets in the hospital, somewhere along the way, they're going to tell about that Happy Feet video with that officer. So here, this fireman, you may not think of his role as therapeutic, but yet he is serving a therapeutic role. And that supportive relationships are actually shown to be the evidence-based practice for the healing the effects of trauma. So when Andi and I do trainings, if we train schools, we like to have the lunchroom folks, the dining folks. At Ballad Health, in time, I want to get all the security trained, the dining. One of the hospitals I visited in Baltimore, Bon Secours, a Catholic charity hospital that's been doing some trauma training, they found of all the folks that patients talk to the most, they talk to housekeeping. So they started training their housekeeping staff. And that raised the value to the housekeeping staff of their level of importance. So we see that in this message that you don't have to be a therapist to have a therapeutic value. And so if you think of a system of care in your community like AED placement, you know, in my lifetime, I remember 15, 20 years ago when this program was rolled out, they started putting this complicated medical equipment in bus stations and malls and universities. And the key to these saving lives was training. And so the passion that we've gone after this in Johnson City has been, if you think about, and this is the opening statement in our toolkit, but if you think of being a first responder and you're at a burning building that's four stories high and they're pulling children out to safety, but on the 4th floor, you see a little face pressed up against a window. You know, we're not content in Johnson City to say, we'll be back in 3 years when we write a grant. to rescue you. But our rationale was, if we can't get there, then we'll train the Boys and Girls Club. We'll train the coaches. We'll train the school teachers. And somebody with training, like the AED, is going to be able to administer this life-saving help to you, which is basically resilience.
So again, to go back to the multidisciplinary team, there's a few things that we highlighted in the toolkit. We're going to go into the toolkit just a little bit. But some of the big take-homes from that are that it's really important for the providers, the service providers, or everyone. We would like to train everyone, actually. But we want people to speak the same language and share the same understanding, so that if you're at one place and people understand that, but you go to the next place and they do something completely different or use different terminology or whatever, that that can be really confusing to the person. And it's like they may not believe the first one, they may not believe the second one, they may think you're talking about two different things. And so just to have this system where people talk to one another so that we are using the same terminology. And also that focus on resilience. One of the things that, it's easy to sit and say, oh, your brain was changed by your trauma and sucks for you. We don't want to leave people there. We want to say, yes, but we have things that we know are effective. We want to support people in their strengths and to have that strengths focus, that resilience focus and so forth, and champion that from organization to organization and across people within the same organization, so that again, that messaging is the same, but it's also hopeful. And as everybody gets on that same page and speaks that same language, what we hope is that there's this focus on reducing re-traumatization, and that we are aware and that's a focus of everyone within the organization, from the front desk to the as you leave to the everybody in between. So a little history of how we got here. That is us, because we're together a lot, and when one of us is here, you've got us both. But this is the cover. Hopefully it will be, it now is in the hands of the state of Tennessee, so hopefully it will be available somehow, somewhere soon. And so that's I say the result of a year of work. It's really the result of the last 4 years of work, but written in the last year. And so I want to give you a little history, quick history, because she gave you some of that. But 2014, she first heard about ACEs and trauma-informed care. And then in 2015, heard Dr. Folletti and Dr. Jungolese at the National Center for Trauma-Informed Care, and came back, created the notebook. She pitched the idea with me there for moral support, as she says it, to some people around ETSU to see who would be interested in that. Nobody bit, and I thought, this is a thing I believe in. I think I'm the one that you're supposed to be pitching this to. And so since then, so much water under the bridge. In 2015, we had the presentation by representatives from the National Center for Trauma-Informed Care here. About 383 people, I should remember that, I do the statistics. 383 people came, and from all walks of life, all different kinds of students and judges and probation officers and teachers and counselors and social workers and whoever, just all kinds of different people came, and sort of it wetted the whistle of a lot of people. And then in 2016, we began doing trainings. They gave us a copy of a draft training, because there really wasn't one developed yet, from the National Center, and we were given really free license to modify that for our purposes. And we started out with a pretty generic training, and now we have a lot of others that I'll talk about in a minute. And to this past year, we have published the toolkit about how to develop that trauma-informed system of care. And so we had the conference, and then they gave us the draft course, and then began to offer trainings. And then very shortly, our first training, I think our first actual training was April of 2016. And then June, we had our first system of care meeting. We just began to invite people every time we did a training. to send a representative to our system meeting. And we started, I think we had 11 people at our first one. Now we have over 100 people that are on our list of whatever, affiliates. I don't know what we call our people in the system. But so we started it then. And since then we've done, I've got over 100 trainings. I have no idea how many trainings we've done at this point. We've shown some movie screenings. We've done talks everywhere. Now we've done more than that. I should have updated that number. We've done 8 Train the Trainers now. So we do one in the fall and one in the spring generally to train trainers, to train people in their organizations, and also in our stead because there's so much demand now. And so getting started, some of the things that we want to say that it only takes a person who gets this and is passionate about it to start a trauma-informed system of care. And it was Becky, and then she talked me into it, and then she was on a board, and so of the Boys and Girls Club, and so our first training was there, and then they were interested, and then they got other Boys and Girls Clubs involved, and then it was like, well, she was on the homeless task force, and so we began to train homeless service agencies, and just wherever we had connections, we'd say, hey, y'all need to know this, and then we would do a training, and then they would tell their friends and tell their friends and tell their friends. So it doesn't matter what role it is. You know, if you teach in a preschool, you start with the preschool. If you are a whatever, you have a bank, you start with a bank. Whatever it is, it doesn't really matter where you are. It's whoever your circle is that can be the starting point. We like to say that it's a message that's caught, not taught, and so we have not had any shortage of people getting it. It's like the lights come on, it's like, oh, yeah, this makes so much sense. I need to tell all my friends. Everybody needs to know this. And so that it really is kind of viral in a good sense. And so what we did when we wrote the toolkit, the 3 main themes in it are to advocate for the training of adverse childhood experiences and trauma-informed care, trauma-informed principles, understanding, and so forth. So advocate for that up front to help people sort of catch the idea that this is important, and then educate more deeply about the ins and outs and the details and so forth, and that leading right into collaborating among people within an agency, among agencies, agencies and other community members. But just this process seems to organize it well. And one of the first things that we did, obviously that first meeting was an advocacy thing. We had experts come in from the National Center to offer this training. They're experts, we weren't yet. And so it was like, hey, friends, come and see this. But also we sprinkled amongst that showing, just having film screenings. We showed Paper Tigers here at ETSU, and we also showed it at the public library. There were showings of resilience. We show healing mean as part of our trainings, but also those could be just have a community meeting and show this just to introduce the topic. And sometimes people will come see a film and they might not come and listen to you, do a class or something like that. But once they see, oh, this really is a thing, then that gives you a chance. Well, hey, we can do more training, or we can train for your organization, or we can connect you with somebody that can do training and so forth. For a while, that first year, there were several places that we just had speaking engagements, like at a lunch meeting or something, one or both of us would go and talk, or there's a CME training in the summer called A Tough Pill to Swallow, where they have various experts come on, talk on various things. You have an hour to present your topic, and people can choose it or not choose it. So just doing breakouts and other meetings and so forth was helpful, just to sort of get the word out. And then once we had done the advocacy piece, it really became training. So developing the trainings, and as we said, we started with the trauma-informed approach, key principles and assumptions. That was a training provided by the National Center that would be an 8-hour training if you did all of it. It has videos that go along with each segment and so forth. And we found that most people don't have 8 hours to commit to a training or to let their employees go to a training. And so we shortened it to about 4 hours. And so it's a lot of instruction and less hands-on. And then what we do is we recommend they do the hands-on part when they go back to their own organization, and we give them some information to take back and do sort of self-study back at their own place. We also are both trained as Tennessee Building Strong Brains trainers, and so we have done those trainings, but we embed that material into the training that we do. So that same language is the language that is in all of the trainings that we do. As we present ACEs, we present it in Building Strong Brains language. And then after about a year, we had such a demand for more training that maybe not, it was probably 6 months, we developed the Train the Trainer, which is really the 4-hour program, but then we intersperse slides of why you should teach it a certain way. Here are stories to interject, so instructional about how to present that program. And since then, we've had a lot of demand for, and always we tried to tailor it to whoever we're speaking to. But if we're speaking to it like a particular organization, we've talked to DCS, we've done DCS trainings, we've done law, corrections training, probation officer training, homeless agency training, people who work with children, people who work with adults, things like that, faith-based organizations. So whatever the people, the group is that we're training, we try to tailor our pictures that are embedded. We try to tailor our stories, our examples to whatever their organization would deal with most to make it personal to them. But then we also have general trainings that we do where it could be anybody. It's like 60 people, and they could be from 50 different types of organizations. And so we keep it more generic, like the original one for that one. And then we have begun to embed some self-care into those trainings. We also did only one training so far that was a self-care training. But those are things to keep in mind as well, because part of this is when you're beginning to empathize with the people deeply that you're serving, there is some potential for burnout and so forth. And we felt it was our kind of duty of care to make sure that people address those self-care needs as well.
And one of the things I just want to chime in on the training is we got underway training at the end of 2015. We got the SAMHSA course, and it was in 2016 that Andi and I first heard about the Building Strong Brains initiative in Tennessee. Mm-hmm. So we were in one of the first cohorts of training in November. Jill Stott, our Northeast Tennessee Regional Director for the Commission, she hosted it, and we were in it. Melissa McGee with SOCAT was one of our trainers, and I think that's the first time I met Richard Kennedy. So we really quickly wanted to align what was going on in East Tennessee. What we were starting to hear now is in Memphis and Nashville. But like Andi said, we stayed with the original SAMHSA training and then just embedded some of the language from the Building Strong Brains in it as well. All right, and then very quickly after we started our first group of training, I'd never really heard the word system of care, trauma-informed system of care, but where I had a monthly partner meeting with my police partnerships. At the time, we called it Crime Prevention Partner Meeting. And we had everybody in there from community gardening to healthcare to corrections to mental health. So I was already used to a multi-agency type meeting. And I knew from that meeting in my $800,000 grant that it helped the buy-in of the partnerships that we met with some frequency. And the reason we settled on bi-monthly was initially a lot of those that were involved were the executive directors or senior level management of an organization. So we didn't really want to over-meeting them too much. So we settled on bi-monthly. And both Andi and I've also worked for ETSU, but in working with the city of Johnson City, I'd written many contracts and worked with legal and risk management. And we knew that it was going to get a bit complicated if we got into a contractual type of affiliation. So we basically said every time we do a training, and still to this day when we train, we offer an invitation for folks to join. So when they sign in on the sign-in sheet, we tell them that every other month we have a system of care meeting and that they're invited to send someone from their organization to join and to just indicate on the sign-in sheet if they want to be added to that list. So some people come and are trained and they don't join the system of care. Now, one thing Andi and I have kind of discerned is it does seem that the groups that follow up and come to the system of care meetings, their organizations are gaining more traction with moving these principles, embedding them more into their services. So our system of care does not require a contractual agreement. It's just we call them affiliates. We also include two things in our meetings, coaching and cheering. We give some continuing education. Sometimes last one we had, a special agent in charge of the FBI in the state of Mississippi, Chris Freeze, he just retired, and he reached out to me and connected over ACES Connection, and he wanted to spend his retirement career being a champion for ACES. So he came to Johnson City, and he attended our system of care. So he talked a little bit about, through the eyes of the FBI, why this was an important crime prevention tool. And then actually when we have our next one in August, I'm connected with a couple of folks in Australia and a nurse practitioner in Perth. We've been Skyping, and another gentleman, and he's going to be in the States, so he's going to be coming all the way from Australia to attend the system of care to learn how to take these principles back. And then we go around the room and we just let the organizations tell. Maybe they changed some signs, maybe they changed some programs, maybe they've done more training, and we're going to tell you next a few things that they've done. And this was the thing that Andi and I, we could have never planned it. And so I just want to encourage all of you that are, whatever role you play in organizing your community effort, is that to really have faith in your community, because when we begin to hand these tools to our community, they begin to do the most marvelous programming, and we would have never known what a cancer research clinic or a library, but they're the boots on the ground in those organizations. And once you hand them the building blocks, one of my favorite videos from the Building Strong Brains training is mental leveling. And so often when Andi and I do our training, we always show that video. And so we talk about, you're the professionals that have the little block. So we're giving you this little block, to go back and to help level the table of those that you serve. And so a lot of our folks that come to that meeting just really say it's a lifeline. People even call it like a family reunion, because somewhere in your organization, someone yet maybe is not totally bought in. And so to get together and have this camaraderie around this topic and how we're moving forward, it's very, very inspirational. So just some of the things as we kind of wrap near the end here that our champions have done. The Boys and Girls Club, as Andi mentioned, I'm on the board there. Well, in the first round of the Building Strong Brain grants for the state, Andi put together a grant, and I was a collaborator, and we partnered with the Boys and Girls Club, and we were awarded a grant. And through the grant, we did training for all the Boys and Girls Club staff. We created a process by which they continue ongoing training with new staff and volunteers. And then we created a calming room. And I think it's always important to include the voice of your consumers as you move into trauma-informed programming. I was speaking in Delaware for the First Lady back in April, and when I finished, someone came down from the steps and approached me with the clipboard, so serious, and they said, I love the calming room idea. Just tell me, what is everything that goes into a calming room? How did you know the science of a calming room? And I said, we asked the kids what made them feel safe. And so literally it's called the Treehouse Calming Room, because the little child, when they were asked, they said, when I feel scared, I sit out under the tree in my yard. And so the calming room is now visited by people all across the state. Back a few months ago, 5 area Boys and Girls Clubs received a $50,000 grant from the Speedway Charities to create a calming room. So now our Boys and Girls Club realize the kids that might be the most frustrating in their behavior are the ones they need to hold the tightest. So they use the calming room to help with the deregulating children, instead of where maybe typically they would have been sent away from the Boys and Girls Club. Our trauma-informed libraries, oh man, our libraries are rock stars. And, you know, we started, when we had this conversation, our librarians started telling us about their libraries. And they're the ones that turn the lights off at 11 o'clock at night, and in a corner in a cubicle is a disheveled woman and 2 toddlers. And that woman is staying there till the lights go out, because they're going to have to go back to a place that might be unsafe. And they see runaway teenagers, homeless services. And so a couple things they kicked off is they have, we've done training for, I think it was about 14 different regional libraries. We trained staff last summer. And so many of them have social work interns that are helping connect. You know, talk about giving meaning to the help desk, you know, instead of checking out periodicals and DVDs. You know, here you can go, and a social work intern is helping you connect to homeless shelters and how to get subsidize your rent or your electric bill. And then as a pilot, they actually started an adult coloring group, and that went so well that now it's a permanent group. And this group of adults, you know, and think about our senior citizens that many are on a fixed income and maybe worries about family members and health and fixed incomes and things like that. And so how better to help bring about a peace through mindfulness coloring. So this group went so well, it's way beyond a pilot now, and it's actual programming. And I've been told the group gelled so well that they actually do trips together. They do use it as another means for senior trips. We also, St. Jude's Research Cancer Clinic, which is embedded in the Niswonger Children's Hospital. Kate Strickland, she was one of the first in our groups of being trained. They're doing amazing stuff. And Andi and I would have never known these things were a need inside of a cancer research clinic. So Kate told me recently that they realized they had a group of about 5 children in the center that had been undergoing chemotherapy for 2 years, and now they're all in a healthy place in life. And this group of children had missed out on daycare and preschool, but now they're kindergarten age. And so they got together with our child life director, and they put together a little life skill class on how to order in the cafeteria and stand in line and raise your hand and introduce yourself and open milk cartons. And I think the staff was more blessed by it than the kids. They had the kids marching around in the hospital, introducing themselves to people, because we know school is overwhelming, much less the fact if you've overcome a life-threatening illness and not had the classroom interaction. Then they started a peer support group with a psychologist coming to help families process anger because of being in this difficult situation. And then they looked at their pain protocol, and they realized Kate, who's not a medical one of the staff, but she's the director of it, she said, you know, I've held children down looking in fear-filled eyes while we put in a port to begin their chemotherapy, knowing all along we had a pain protocol that was a pain cream, but it would take 20 minutes to kick in. So we'd really not ever offered that. And they decided as a group that we were going to begin immediately in their intake that every single patient has the option for pain cream, which now it's usually the preferred method. So the nurses and the social workers just play with the kids and work puzzles and things during those 20 minutes while the child's waiting to get their port put in. We're trying to advance the slide here. Okay.
Oh, too far.
Then we have a group which is really quickly becoming known statewide. Oh, yeah. Yes, Isaiah 117 House, kind of a brainchild of Rhonda Paulson and Corey Paulson. Rhonda asked Corey to go on a date night and kind of on the way said, well, I'm sort of tricking you. We're going to foster care classes. Talk about a date night. And so as they went through the PATH classes, the last night they're at the DCS office, and the worker said, and this is where you'll pick up your child. And matter of fact, last night we spent the night here with a child, and as Rhonda's just looking around the DCS office, and no fault of DCS, you can't find more compassion than you can in many of our caseworkers in DCS, but she started to cry, and she said, wait a minute, a little child who none of this is their fault? So she and Corey talked after that, and they came up with the idea to get a home that was warm and friendly and food and a bath. And so it's partners with DCS. So the DCS caseworker comes into the home, has always constant visualization of the child, but the child can have a bath and pick out clothing, take a nap, have a meal. And many of the children now are saying, who is this house for? Who are these toys for? And Rhonda, after all her staff and volunteers have gone through trauma-informed training, they're telling the children, these are for you, because this is not, this day, which is so hard, that this is not your fault. And the communities are rallying around. They have several more that are breaking ground. Governor Lee was just here last week breaking ground on one in one of our counties. And the fire department, they've helped to decorate the original one. They were telling at the ribbon cutting, I was there with the mayor of Johnson City, and the firemen were saying, we found that on Pinterest. Who knew firemen are using Pinterest? But that's the way our communities join together. And then Topper Academy, the alternative school, Miss Ryden Bacon and her staff, they were in a training in the summer of 2017, and Ms. Ryden Bacon asked her staff if they would give her 1 year for complete buy-in together as a staff, that they would work to do a trauma-informed approach. So Andi and I trained all their staff. They watched Paper Tigers, and then for the first year, we went to every month to their in-service, and their coach, Coach Malone, said, let's do a book study. So they did Fostering Resilient Learners by Kristen Sowers and Pete, I don't remember his last name, a principal. We did some great things, and the staff just bought in. And the first year, our newspaper put it as a headline, the first year attendance went from 55% to 88% and remains there this day. In the first year, 140 students would typically recover 200 credits. They recovered 1,155 credits. Typically, they would graduate about 8 students. Every senior graduated the first year, 65 seniors. Last year, 44 seniors. Last year, they earned 1,044 credits. And the staff said they would never return to trying to conduct school without a trauma-informed approach. And then we have our domestic violence programs. We have 2 family justice centers, one in Washington County, Johnson City, and one in Sullivan County. And they've incorporated the faith community. They realize that when a survivor comes in, that sometimes they just leave with the clothes on their back. So they put out a word to the faith community, who made these nice little suitcases that are filled with every imaginable size of undergarments and clothing and toys for children, and these are available for no cost when victims come in to a family justice center. And then trauma-informed policing. I heard a 911 call one day of a 4-year-old calling 911 because he was watching his mother being beat with a ball bat. And as a mother and a grandmother, I said to myself, who's going to help that child? Because what they don't understand is when they leave that call, out the door is going to go their father in handcuffs. And so I thought, what if police could be an intervention? So we created trauma-informed policing, and people often ask, how in the world do you get in the door to train police? And so in our toolkit, we said that one of the greatest ways is to introduce Handle with Care. Police are very interested in school safety. Most schools provide SROs to our schools. And so if you set up a meeting with the chief of police, the school superintendent, I generally try to include the mayor, and just make a presentation on Handle with Care. And then we also make it known that there's training for leadership in the school as well as police. So I created a trauma-informed policing training, all based on information that came from the National Child Traumatic Stress Network, geared to police, as well as the International Chiefs Association. And while I was at the police department, I submitted it to the post accreditation in Tennessee, And so it's accredited in the state of Tennessee. And now that I've been working with Oklahoma City, they've gotten it accredited in the Oklahoma City and in Oklahoma State. So it's certified in 2 states. I'm actually working with some law enforcement maybe now in the state of Virginia to get it certified there. So it's really taking off to train law enforcement on how to reduce trauma on scene, as well as how to address officer self-care. In 2018, more officers committed suicide than were killed in the line of duty, and 95% of officer training is all around addressing the second leading causes of officer death, while a very small amount of officer training is geared to address officer trauma and secondary trauma.
And one of the things that I've been really involved in lately, which has pulled me away some from doing a lot of this, is I'm executive director for what we call the Holy Friendship Collaborative, which is a grant-funded organization that we're trying to mobilize the faith community to address addiction in our area. And but along with that, and some of that came out of understanding the connection between childhood trauma and eventual addiction. And so we're looking at the faith community as being an army to come alongside people who struggle with addiction. But along with that, what we want to do is help them understand some of the whys that people might be using substances or abusing substances. And so we developed a trauma-informed care training specifically for faith-based organizations, which both ties it to addiction, if indeed that's what they're focused on, but also looks at the scriptural basis of trauma-informed care principles, which align beautifully. I ended up presenting that at a research organization spring before last, just showing the overlap between them. We kept wondering, why does this make so much sense? But it does, and that gives us a foot in the door with churches as well. And when we talk about a system of care, we've got the system of care, but within that, one of the elements of that system is the faith community, which is a system in itself. So by tapping into that community, our system explodes because we have so many faith-based organizations in the area. And so we've had several trainings that are specifically trauma-informed care training for faith-based organizations, but we also promote trauma-informed care through our organization. So one of the trainings that we advertise that all churches really need to have is trauma-informed care training for their congregants. So that's a real push that I do, and then I do a lot of those trainings, and now I'm about to train 2 more trainers to do those trainings. And then also ETSU, you would think, having worked here for 24 years, they would have bought into this as soon as I did, but it took a little longer for some people. But there's several of us here, and some of you, I'm sure, know some of us. Michelle Mosier is one, and I'm trying to think who else. Anyway, there are several different, you can see the departments that are involved, but we have started a kind of a grassroots group called the Brain Trust, Building Resilience Through ACEs-Informed Networking. And what we're trying to do is become a trauma-informed university, like from not just the coursework, although we have some coursework already that's trauma-informed principles and ACEs information, but infuse that throughout the curriculum so that all of our students leave with an understanding of that, but also having trauma-informed services throughout, so that the faculty, the financial aid, the cafeteria workers, that we've already trained a lot of the public safety folks, so that it is throughout the organization, so truly trauma informed. And so we're in the process of that. We also would like to bring together, because several of us have had Building Strong Brains grants, and we do research in that area, and we would like to not just train everyone, but also to have a repository for the research findings and the dissemination of that, and the kind of a hub for doing training in the area and so forth. So that's a work in progress. This is an early snapshot, but hopefully that's going to continue to develop and become a priority. President Nolan, who is our president here, is backing us on this, and we're hoping to develop either a center or an institute or something like that so that we can sort of gel all of those things in one location.
And then I was offered a position to come here at Ballad Health last November, so since moving to Ballad Health, we have 21 hospitals in 2 states, 21 counties of Southwest Virginia and Northeast Tennessee. So it's really rural Appalachia, which is really a epicenter for drug-addicted babies. The children's hospital that I work in, we're looking at raising $50 million to build 2 more floors. We have multiple counties in Tennessee and Virginia that have 58% or 58 out of 1,000 babies being born addicted. A typical county is 6 or 7 per 1,000, but we have counties 58 of 1,000, 55 of 1,000, 100 of 1,000. And so instead of a war on drugs, we've launched a war on trauma, and we're looking at trauma as the gateway drug to trauma, drugs, and crime. Andi and she got very involved in my work at the police department with the felony offenders and a reentry effort, and so many stories where they're choosing unhealthy coping mechanisms, which largely are drugs. And then once you get involved in drugs, there's going to be crime to help sustain that. So we started training schools. Boy, this summer has just been super rewarding. I've been training every single teacher in Buchanan County, every principal, the school board members. I've made 3 trips to Grundy. I'm going to go back and train their SROs. I'm Monday going to train every single teacher and principal in Hancock County. I've been 3 times to Johnson County, training every teacher in Johnson County. I've been training Bristol, Virginia. I've trained all the principals. Now we're getting ready to train all the teachers. It's just, to me, it's just so rewarding and humbling. Also, we're spinning off more systems of care. So really, we've been able to prove that this model is replicable since I've come to Ballad. So Margaret Feyerabend, the mayor of Bristol, she really bought in early in the conversation, and she has a nonprofit, Bristol Promise. It's Bristol, Virginia, Bristol, Tennessee, and they've launched a second system of care with, last time I was at it, they have 40 or 50 stakeholders already coming. We're getting ready to launch a second one with Kingsport United Way is going to be our facilitator. So as we kind of wrap this up, one thing I just kind of want to say is, you know, wherever you are in an organization or whatever kind of organization you are, there's really not any kind of specifics that it has to be a certain role or have to be a certain kind of organization. All it really takes is your understanding of the urgent need to reduce childhood trauma. So we've got more systems of care spinning off. And then also I'm working to train Ballad team members so that we can become actually a trauma-informed healthcare system. And we just had our first conference with Liz Murray, Homeless to Harvard, best-selling author, and just a powerful story, Dr. Stephanie Covington, who's legendary in a lot of this work. And so we are planning to be partners with Tennessee Commission was a sponsor, Camelot Foster Care, ETSU, to do a collaborative type conference each year.
Now I'm going to fly through some data because I know we're almost done. So what have we learned? I mentioned that we started very small. We had 11 people. Now we have average attendance 20 to 30, sometimes bigger. We have more than 25 organizations that are signed on as systems of care. We've got many more organizations that have been trained. We did some focus group with our system of care members in December and just asked them about what's good, what's bad, what should we do different. They do like the coaching, cheering, value the meetings, and so forth. They love the time to share and find out what other people are doing. They're interested in continuing education credit and maybe mapping where all the other organizations are so that they can make sure that they're referring to other trauma-informed organizations. And so that's some of the follow-up. We do measure I am the measurement junkie here.
Yay.
But from before we ever started, we have been tracking how familiar people are with just trauma-informed care. We also have been tracking how trauma-informed organizations are. I've got just an example here. So like the the familiarity with the term, we've almost maxed out. People have heard of it, but there's still work to be done. This is trauma screening. There's also budgeting and organizational structures and things like that we measure regularly, and those are slower but coming along. And so people are beginning to shift the needle in a lot of these organizations, and so we're going to continue doing that. And so one of the things that we do recommend in the toolkit is to just come up with an evaluation plan so that you are keeping an eye on how things are going. And with these other two systems of care in the area, they've just asked for our evaluation tools, and we give them freely to anybody that wants them. I think we included them all in the toolkit. Yeah. So I mean, we don't own it. So if you want to evaluate a different way, that's fine. But we're glad to help anybody do what we've done and not reinvent any wheels. And it's 3:00.
Yeah.
Yeah. Andi and Becky, I just want to address everybody that's on this webinar or might be listening to this webinar later. We are so grateful for you. And a lot of times when we are talking about adverse childhood experiences or presenting our Building Strong Brains curriculum, people struggle. They're like, okay, I'm bought in. What do I do? And the beautiful thing about this webinar and this toolkit is you all have really showcased 50 different ways, that one can respond and lead from where they are, where in their respective community or their respective sector. But I'll have to say, Andi, I love that at the end you're like, but make sure you measure it, right? Because we need to be able to know that we are actually making the changes that we think we are, right? And so that others can replicate this. So I am just so excited that we now have this resource as a state. Again, if you are interested in having access to this toolkit, you can reach out to Becky Haas or Andi Clements. I appreciate your time showing this with us and sharing your information, and I appreciate your candor and your passion. You two, I have such great respect and admiration for your work and the way that you're changing lives for children, youth, and young adults and infants and toddlers in Tennessee. So thank you again. Again, to everybody who's on the line, this will be recorded. It will be uploaded to YouTube, but we have run out of time for questions. So if you have questions, I'm sure that Becky and Dr. Clements would not mind you emailing. Am I right about that?
That's fine. Yeah, that's fine.
Okay. Good deal. Well, listen, everybody, thank you again, and I hope that each of you has a great rest of your day.
Thank you.
Thank you.
Okay, bye-bye.